Welcome to the latest edition of the ECG 5-Minute Consult, JEMS' ECG of the Month, brought to you by paramedic Troy Kennedy, Dr. John Hayden, and myself, where we teach you foundational ECG knowledge using the primary survey approach from our book, ECG for First Responders, available on Amazon. Let's take a look at today's case. You arrive on scene to find a 46-year-old male who works as a banker. He appears anxious and diaphoretic and states that he has left-sided 10 out of 10 crushing chest pain that radiates to the jaw and left shoulder. He has a history of hypertension, hyperlipidemia, and a 20-pack-year smoking history. His hypertension is poorly controlled as he states he does not take his prescribed medication regularly. Now, we need to obtain a 12-lead ECG on this patient, but first let's briefly review our primary survey of interpretation. As we examine this patient's ECG in the context of a primary survey, we will be seeking to answer these 4 questions. First, the rate. Is the heart rate too fast or too slow, causing cardiovascular instability? 2. Rhythm. Is the rhythm supraventricular or ventricular in origin? 3. The ST segment. Are the ST segments consistent with an ST elevation myocardial infarction, STEMI, or a non-ST elevation myocardial infarction, NSTEMI? And lastly, the T waves. Are the T waves consistent with a STEMI or NSTEMI? So let's take a look at our patient's ECG while answering these 4 questions. First, the rate. We will pick an R wave that falls on a bold line of the graph paper and then count large boxes moving backwards. The more large boxes we count between R waves, the slower the corresponding heart rate will be. So starting here, we will count 1, 2, 3, 4. That's 4 large boxes between R waves, giving us a rate of approximately 75 beats per minute, which is within the normal range of 60 to 100. We obtain a full set of vitals, and this gives us a blood pressure of 160/100, the heart rate we already determined to be 75, respiratory rate is 18, SpO2 is 92%, and the patient's temperature is 98.6 degrees Fahrenheit. So judging by this patient's heart rate and blood pressure, he does appear to be hemodynamically stable for this moment. But that could change very quickly. So let's move through the rest of our survey without delay and make some important decisions regarding our approach to his care. While examining this rhythm, we can see that the QRS complexes are spaced out at regular intervals, and each is preceded by a P wave. Additionally, if we look at the QRS complex itself, we can see that it is narrow, that is less than or equal to 3 small boxes wide, or 0.12 seconds. So taking all that together with the normal heart rate, we can say that this rhythm is most likely supraventricular in origin. Assessing our ST segments for signs of elevation or depression, we can see that there is upsloping ST segment depression in leads V2 through V6 contiguously. There's also slight elevation of the ST segments in AVR and AVL, and what looks to be reciprocal ST segment depression in the inferior leads 3 and AVF. These findings are actually indicative of an anterior wall myocardial infarction. I'll explain this in more detail, but first let's take a look at the T waves as they play an important role in this diagnosis. Looking at the T waves, we see that there is an upright T wave in V1, which is abnormal. Remember, on a normal ECG, there should be inverted T waves in AVR and V1 only, and upright everywhere else. In addition to that, we can see that there are inverted T waves in leads 3 and AVF. Now looking at leads V2 through V6, we can see that they have tall peaked T waves that are accompanied by that aforementioned upsloping ST segment depression. Now, a question to test your knowledge. The findings from this patient's ECG most likely indicate occlusion of which of the following coronary vessels? A. Right coronary, B. Left marginal, C. Left anterior descending, D. Right marginal, or E. Circumflex. The correct answer is C. Left anterior descending artery. If we pull up this patient's ECG and take a look at the T waves again, we'll find that those tall, prominent, peaked T waves accompanied by upsloping ST segment depression fit the criteria of De Winter T waves. Now, these were first described by Dutch cardiologist Dr. Robert De Winter in a study published in the New England Journal of Medicine in 2008. So even though we don't see ST segment elevation in the precordial leads, the finding of De Winter T waves has a positive predictive value between 95 and 100% for left anterior descending occlusion.
This type of MI is referred to as the widowmaker because of its historically high mortality rate. That's because the LAD carries almost 50% of all the blood in coronary circulation, supplying blood to the myocardium of the anterior wall, the anterior 2/3 of the interventricular septum, and to the apex of the heart, where it anastomoses with the posterior descending artery in most individuals. Now, this is a rare finding, but very important for you to be aware of so that you don't miss it in one of your patients.
Well, that's all for today. We hope you've enjoyed this edition of the ECG 5-Minute Consult. If you'd like to learn more about ECG interpretation, check out our book, ECG for First Responders, available on Amazon. Thanks for your support, and we look forward to seeing you next month.